For those of you that I have not met, my name is Marla Gordon. I'm the Director of Clinical Services here at Kendal at Home. Thank you for joining us today. And we are happy to have Anna Myers with University Hospital's Urology Institute with us today to discuss urinary tract infections, the signs, symptoms, and consequences if left untreated. So thank you for taking the time to be with us today, Anna. And before I turn it over to you, just so everyone knows, if you have any questions along the way, feel free to click on the chat button at the bottom of your screen. You can type those questions in and we'll take a look and answer those at the end of her presentation here. All right, well, thanks for being here, and I'm going to turn it over to you.
All right, it's a pleasure to be here with you today. This is one of my favorite things to talk about and to help women and men both with is urinary tract infections. When they reached out to me, Marla did, about this, she brought up the fact that a lot of patients, or not patients, a lot of the clients that work with Kendal at Home, that there had been some issues with some urinary tract infections that people were having, and that they were just kind of getting on caught at the last minute, and they were quite sick. So we're going to go through what urinary tract infections are. We're going to talk about all the kind of lingo that you hear around it, and we're going to use the most up-to-date guidelines from the American Urological Association to go over this information with you. So UTI. A lot of times people hear that and they don't know exactly what that means, but that's a urinary tract infection. And I have a diagram over here to the right. And, you know, we think of a bladder infection, but it really could be anywhere along the urinary tract system. So we're talking about the kidneys, the ureters, the bladder, the urethra. It occurs in greater than 50% of all women at some point in their life, and 12% of all men will experience a urinary tract infection in their lifetime. And oftentimes we see these urinary tract infections kind of occur, particularly in women, at certain times of their lives. You might remember when you're younger, around this time you start to become sexually active, that there's kind of a time when more women will get urinary tract infections. And then after they go through menopause, we'll see it again. And we're going to talk about the reasons why that happens during this presentation. So a UTI is symptoms that are localized to the urinary tract combined with evidence of inflammation, which is pyuria. So that's one of the words that you hear sometimes, which can be noted on the urine, and with a urine culture that's positive that identifies a urinary pathogen. So not just the irritation, but we also have a bacteria that we can link it to. This is different from cystitis, which is often what you'll hear somebody say. They'll say, oh, they have cystitis. That implies inflammation, but not necessarily an infectious etiology. And our goal as a urology provider is to identify risk factors for recurrent infections or complications and try to mitigate that the best we can. So the big job that I have is to find out what your risk factors are if you're getting urinary tract infections and try to minimize that so we can prevent the next one. We hear the word bacteriuria, and that just means simply bacteria in the urine. And that doesn't necessarily mean a urinary tract infection, because you can have, as we'll see, the next word is asymptomatic bacteriuria, or ASB. And that's the presence of bacteria in the urine that causes no illness or symptoms. And we find that is particularly women and also men as well, as we get older, it is common, or there's an increase in the amount of asymptomatic bacteriuria as we age. Pyuria, that is white blood cells in the urine. So again, that doesn't necessarily mean an infection. It could be inflammation. It could be some other cause, like a tumor or something like that. Acute bacterial cystitis, and that's a culture-proven infection of the urinary tract with the bacterial pathogen, and it's associated with an acute onset of symptoms, including burning, perhaps in conjunction with urinary urgency, frequency, blood in the urine, or new or worsening incontinence, so leaking urine, not making it to the bathroom in time, waking up already wet, or pelvic and back pain. That said, a lot of times as women age, they don't really have those symptoms in men. They don't have those symptoms that are typical when you're younger that I just described. they'll have what's more of an atypical presentation, perhaps. And that might be, they'll say to me, well, I started noticing I was getting up more at night, or I started noticing that I was leaking a little bit more. And that's kind of usually the like first sort of symptoms. And then it can become symptoms such as altered mental status. And they don't know what causes this. We don't have a cause for that. Or nausea, vomiting, falling. So if you notice like your neighbor, and we're going to talk, I'll remind you about this again, but like if you notice a friend, if you notice a neighbor, if you notice that they're just, things aren't quite right, or maybe they say to you, I've been getting up at night a lot at night, and this hasn't been their typical, they need to get it checked out because that could be an atypical symptom occurring. Recurrent urinary tract infections is when we have two separate culture-proven infections that are associated with symptoms within 6 months or 3 within a year. And that would mean that you really need to get evaluated to find out what's going on. Why are you getting all of these recurrent infections? An uncomplicated urinary tract infection. So we sort of divide our infections up into uncomplicated and complicated. And you'll see this on your paperwork oftentimes. Is an uncomplicated is a urinary tract infection in a healthy patient with their anatomy is working correctly. They have a normal urinary tract. There's no known factors that would make them susceptible to develop an infection. A complicated urinary tract infection, they have one or more factors that increase their risk of developing UTIs, and potentially it decreases the efficacy of therapy. So that's why we have to kind of get into the nitty-gritty of that. Complicated UTIs, we think about a male patient. It's not as common as it is in women to have urinary tract infections for men. Diabetes, immunosuppression, pyelonephritis. So if you get an infection in your kidney, that's a big deal. That's a more complicated urinary tract infection. Resistant organisms, if you're having organisms that are not sensitive to the antibiotics. Maybe a difference, something different is going on with your anatomy. Perhaps you have like a prolapse. So with women, sometimes the vagina, the bladder will come down and then they won't be able to empty as much. Or with the men, you think about the prostate, they're not able to empty as much. Certain types of bacteria that I have listed here, a number of bacteria that can occur that are more complicated to treat. So pyelonephritis, so like I said earlier, a kidney infection, that's an inflammation or infection of the kidneys, typically arises from the ascending genitourinary tract infection. So that means it can go from the bladder up into the kidneys. And a persistent UTI is, we treat you with antibiotics, but you still stay sick for some reason. We have to figure out why. There's, I want to say we have like the top 10 list for lots of things, but we have our top list for bacterial and agents that cause urinary tract infections. And the number one of the number one bacteria is E. coli, but it's the uropathogenic. So this is not E. coli. People ask me, is this like from eating spinach that's come from another country that's not been washed properly, or there's bacteria, or this from bad whatever kind of food that they eat at a restaurant? No, this is not where that urinary tract infection comes from. And then there's a number of other bacteria, Enterococcus, Pseudomonas, Staphylococcus, Klebsiella. Those are like in the top 5 types of bacteria, but E. coli is clearly the most common bacteria, and that's in about 90% of the infections. We have risk factors for women for the urinary tract infections and genitourinary syndrome of menopause. Now that might be a new term for you because that's kind of a term that's just now making it into the mainstream. Previously, if you've seen it on your records, it probably was atrophy of the vagina. They didn't really like that terminology. It doesn't sound really good to say something's atrophying. So genitourinary syndrome of menopause, and see that, and what that is as we lose our estrogen, we're going to talk about this more, but that's estrogen from the ovaries, from our eggs. That's what gives our vaginas the acidity that keeps the bacteria down. It brings blood flow to that area, thickens those tissues, helps with lubrication, arousal, orgasm, all those things. But it also helps with preventing infections. So as those eggs die off, we lose that estrogen that goes to the vagina, and this is genitourinary syndrome of menopause. Sexual activity puts women more at risk for urinary tract infections. Just takes a little bit of irritation and that bacteria can get right in there. Personal history of UTI. So women that have had a history of urinary tract infections in their lifetime are far more likely to have urinary tract infections as they get older. Prolapse, as I discussed before, if you're a woman, then your pelvic floor would drop, like the bladder would drop inside the vagina. You might not be able to empty your bladder as well. So if you're feeling like you really got to push or you can't get your stream started, that would be a sign of a prolapse. Constipation and or diarrhea. So location. Having a stool that's not being evacuated from the rectum puts more bacteria in that part of the body. And you can be as clean as you want to be, but microscopically that bacteria is just in a close location to the woman's urethra. And some women's urethra is shorter, they say, so that can also perhaps put them more at risk. And that's nothing you can control, but you can control the constipation. And diarrhea is another issue. Again, obvious reasons why. Risk factors for men, we talk about BPH or benign prostate hyperplasia. So the prostate, as it enlarges, it doesn't just enlarge on the outside, it enlarges on the inside. So that makes it difficult for men to empty their bladder. And so what we have there is we have a bladder that's not emptying. And then just like with the prolapse, that urine is sitting in there and it's not, coming out the urethra. Urinating is a preventative measure for urinary tract infections. That's why drinking fluids enough and urinating, you're pushing that bacteria out. And if that urine is just sitting in there and not emptying out, you're more at risk. So that's what the incomplete bladder emptying and then in the incontinence. So what do? We want to get a good evaluation going to find out why somebody is getting urinary tract infections. And I know that when you have your annual follow-ups with your primary care, they're asking, have you had any urinary tract infections? But this is the kind of evaluation we would do if you're having frequent urinary tract infections, or if you've had a few and you come and see a urology provider. So we'd want to get your history. We'd want to find out, when are these urinary tract infections occurring? Do you have a new partner? I have women there or men, their partners have passed away, particularly women. Their partner has passed away and maybe they've developed a new relationship and they're starting to have intercourse, and perhaps they're starting to get urinary tract infections. Infection history, past urinary tract infections, if you've had them before, as we discussed that being a risk factor. And what were the cultures and the results of the cultures? Were they resistant bacteria? Or were they, and by that I mean like it was difficult to treat. That a lot of antibiotics didn't work for this particular bacteria. And then the other thing would be, what type of bacteria? Is it a common bacteria like E. coli, or is it one of the ones that is less common? Anatomical abnormalities. If something, is occurring that's keeping the kidneys from emptying, let's say you have a kidney stone in your ureter, or you have a bunch of kidney stones and your kidneys are not emptying appropriately. Or perhaps you have a special kind of congenital condition like a horseshoe kidney, which those kind of patients, oftentimes we see they have a lot of different kidney stones and they're a little bit trickier to treat. We look at your voiding history. How often are you urinating? Are you urinating only 3 times a day? And that tells me you're not drinking very much and you're not emptying your bladder often enough to keep that bacteria from building an army in there. Are you having difficulty urinating? And are you taking any medicines for overactive bladder? Because when you take a medication for, let's say, overactive bladder or urinary leakage, it could work too well, and that puts you at risk of not emptying, and I gotta kind of watch for that too. What is your bowel history like? And we've talked about those reasons that's important. And social history. Do you have a history of smoking multiple packs a day for multiple years? Do you have a history of, smoking 1 pack a day, but for 50 years, that kind of thing? We want to rule out any risk factors for cancers or blood in the urine. We want to look at your sexual history, and we talked about that. It's important if you are sexually active using lubricants, because lubricants can help with that friction that can introduce bacteria so easily. And your STI history. We want to look at your family history. Is there urinary tract infections in your family? Did your mom get a lot of UTIs? Or did they have kidney stones, your parents? Because we see that often in families. Your pediatric history. Did you have surgeries? You would think that wouldn't matter at this point, but actually perhaps it does, because if you've had to have, maybe you were born with a congenital condition and you had to have a surgery when you were younger, you know, we have to make sure you're not having issues because of that now. Have you had any recent hospitalizations? We know that folks that have been hospitalized, they sometimes have had a catheter, and that puts them at risk for urinary tract infections. Diabetes or a spinal cord injury. Perhaps you wouldn't be emptying your bladder as well if you had a spinal cord injury. Surgery history, spinal surgeries. It causes you often, not often, but it can cause you to not empty your bladder as well. Urinary kidney stones, bladder, prostate, renal, ureteral surgeries, or prior vaginal mesh. Like in the early 2000s, when somebody would have a prolapse repair, they were using some vaginal mesh that sometimes would erode into the bladder, and that would cause, you know, a foreign body that bacteria could stick to and could you know, cause women to have more urinary tract infections. Medication history. Have you been on any recent antibiotics? Are you taking any pain medicines? Pain medicines cause constipation. Steroids or immune compromising agents, that makes it more difficult to treat some UTIs. We want to do an evaluation with laboratory testing. And obviously we're going to be taking your urine, and we have a few different ways of doing that. And so it's a little bit confusing. Like, you see that they have those little sticks in the office, and they'll dip it, and it has little color codes on it. And we have a little machine that we put that in, and it gives us some information that is quite valuable. One is the leukocytes. You'll see this on your paperwork probably. And that can indicate the presence of white blood cells, 5 to 15 white blood cells per high power field. Nitrites, that's a bacteria converts nitrates to nitrites, and that picks up that nitrite. So it's a sign of bacteria. Blood, and that could be, or they'll call it heme, and that can be a sign of blood in the urine, or hemoglobinuria or myoglobinuria. Glucose is an indication. If I see that in the urine, that's an indication that their blood sugar is at least probably around 350 at a minimum. If I see like 500 of glucose, that typically means that. And that means either you don't know that you have diabetes, or your diabetes perhaps isn't controlled, or perhaps it means that you're on a medication for your diabetes that gets rid of your glucose through your urine, which can also increase some of the urinary tract infections too. Limitations of the dipstick is that we can have false positives, and we can also have false negatives. So there is a chance that it might not be accurate. So even if it's negative and you're symptomatic, that doesn't necessarily rule out that you don't have an infection. Urine microscopy, that is where we take the urine and we send it away to the lab. They spin it down in a test tube, they dump out the liquid part of it, and they take the cells and they put them on a slide. And when they put them on the slide, they look through the microscope at that slide, and they can count up the number of white blood cells, and they can count up the number of red blood cells, the bacteria, the crystals, and we can truly see if it looks like you have an infection or not. And that gives me a pretty good indicator right away, because if I have somebody that's having symptoms, let's say they come in and I send the micro away and all I see is blood, or that's all they see, you know, they very well may not have an infection. They might have, let's say, a kidney stone or something going on. The laboratory testing continued. We're going to talk about urine culture. So 10 to the third colonizing forming units is deemed to be a UTI by definition. So a tiny bit of bacteria, they don't really consider a urinary tract infection. but you'll see like these kind of numbers that are like 30,000 or 50,000 or 100,000. So this would be like the 30,000, and that would be the minimum amount. It may take a few days to get that culture back. So they're going to take that urine, they're going to put it on a plate, you know, like a little petri dish, and they're going to grow it, and they're going to see if it grows into bacteria, what kind of bacteria, and then they're also going to test it with the antibiotics to see which antibiotics work. There's also some new technology you may be starting to hear about. It's actually been around for about 5 years. I've been using it, and that's PCR testing. And there's a lot more DNA testing, and that's what it is coming out. And that's where we send the urine away, and they just look to see if there's the DNA of the bacteria in the urine. So they will also grow a culture too, but they are really primarily doing this to see if there's bacteria. So somebody that doesn't test positive with the urine culture, the typical way that's been done for many decades, we have now a DNA test, but they do cost quite a bit more. However, used in the appropriate way, they can give you, you know, information that's, you know, quite informative. All right, so let's talk about recurrent urinary tract infections. So when that's going on, that's like what we talked about earlier. That's, you know, 2 UTIs in 6 months, 3 in a year. We want to get some imaging because we want to make sure there isn't a tumor, polyp, kidney stone, something going on that's, you know, keeping that bacteria going. And then there's also another test called a cystoscopy, which you may have heard of before, and that's a procedure we do here in the office. It's a tiny little catheter with a light on the end, and we're taking a look inside the bladder to see if there's anything going on. Like I said, tumor, polyp, you know, kidney stone, anything that could be keeping that bacteria going, or diverticulum, something to that effect. This is the good stuff. So the prevention of the recurrent urinary tract infections. As we said before, many women develop UTIs with specific life changes. So as we talked about, you know, becoming sexually active with a new partner, maybe after a back surgery, after, you know, constipation, those kinds of things. And we know that there's changes in that periurethral tissue, as we discussed before, in peri and postmenopausal women. And this is despite if you're even on systemic estrogen, because we know hormone replacement therapy doesn't always necessarily get to the vagina, that it's actually putting the estrogen cream, the estrogen tablet, the ring, the device, all of those kinds of ways gets the estrogen right where we want it. Prevention of recurrent urinary tract infections continued. Increasing water intake to 1.5 liters per day. And I always say, like, if you know, you want to drink till your urine is clear to pale yellow. So some people aren't able to drink 1.5 liters a day. If they have congestive heart failure, if they have kidney issues and their doctors are keeping them on a limited, you know, if they have issues with sodium, that kind of thing, they have to watch their fluids. So this isn't for that person. This is for people that don't have those issues, but increasing their fluids so that they're urinating, you know, every 3 to 4 hours, something like that. Cranberry. You know, it's an old kind of remedy, but I have a lot of patients that use it and it works to prevent urinary tract infections. And particularly as we're going to talk about here with D-mannose. But the idea behind it is that the bacteria cling to the sugar in the fruit, and then they don't cling to the lining of your bladder. So we have a picture of, that's my cranberry picture right there on the side. And then when you're drinking all your fluids, you're flushing that bacteria out. Methenamine salts. So this isn't oh, I skipped over vitamin C. Vitamin C just acidifies the urine. It boosts the immune system. It's good for all of us this time of the year, especially with all the different things we've had going on the past few years, trying to, you know, keep healthy. Methenamine salts, that is a salt that has antiseptic properties. You'll hear it's called methenamine hippurate. It's not a first line preventative measure, but if other things are not working for you, it is something that can be tried. And I do have a few patients that do that, and it has been helpful for them. Probiotics, controversial, because, you know, the research isn't necessarily proving true, but it's not going to hurt you necessarily unless you are going through cancer treatment. I'd probably be a little bit more, you know, I would talk with your oncologist about that. But generally in a healthy person, taking a probiotic to replenish the good bacteria that's getting wiped out when you take an antibiotic. So if you take an antibiotic, it doesn't just eliminate the bad bacteria, it eliminates the good bacteria that kind of keeps things in check. So we know, we're learning that there's things going on in the microbiome of the vagina, of the rectum. We're doing studies trying to figure that out. So it's not, you know, completely, the information isn't complete yet, but it might be helpful. D-mannose, as I talked about earlier with the cranberry, very effective. There is science behind that. In Europe, they use it to treat UTIs. Here, we just use it for prevention. But I have lots of ladies, you know, young and older, that like D-mannose. They feel like it's a real game changer along with the estrogen cream. Bowel management. So as we discussed, managing constipation aggressively, whether you need to add some psyllium fiber, which is Metamucil, or Miralax every day, something like that. If I can't take care of it, I have you see your GI doctor or your primary care for their recommendations, but those are things that you can get started with that are, you know, can easily work on constipation. And then vaginal estrogen again. The urinary syndrome of menopause, we've talked about that at length. It just alters that microbial flora, leading to less lactobacillus, which is the good bacteria colonization, and more of the bacterial colonization of those other bacteria. So once again, I want to remind you, do not ignore minor symptoms. Increased frequency or incontinence, which is the leaking of urine, getting up at night more. These may all just be minor signs, but you know, if they're occurring and you say to yourself, this isn't my normal, or this isn't my friend's normal, speak up and go get checked. Get help. We want to catch it before it gets to the point of vomiting, pain, confusion, because, you know, it can become quite serious. You can go to a point of what they call sepsis, where your body's reacting to the infection, and your blood pressure can drop, your heart rate can go up, those kinds of things. You can have trouble and end up very sick with a blood infection. You want to get checked right away. You want to see your provider and request that your urine be tested and a culture sent. And if you're having complicated urinary tract infections, recurrent urinary tract infections, you want to see a urology provider for evaluation and discuss prevention. And prevention. I can't say enough about that. So I work in Northeast Ohio, near Cleveland, in Parma, Westlake, and Lyndhurst, and that is the phone number to reach me if you would like, you know, to contact me for more information or appointments. All right. I wonder if we have any questions out there.
Thank you so much, Anna. So much great information. If you have questions, feel free to click on the chat at the bottom of your screen. You can type those in and we will take a look at those, and Anna will try to answer those for you. If you want to stop sharing your screen, that'll be great. There we go. I was talking with Anna before we started here and just relaying the fact that our care coordinators so often are kind of catching those symptoms in the members here at Kendal at Home and seeing some of that confusion or falls that have suddenly become an issue for someone that didn't have a problem before, and recommending that doctor test their urine, and they in fact are coming back positive with urinary tract infections. Now that they have those strips that you can get in the drugstore, what are your thoughts on those? Should they be utilizing those kinds of tools?
It depends on the patient. It's a good way to perhaps maybe rule out that there isn't one going on for my ladies, or I would have said that in the past, you know, before DNA testing, for sure. I would have used them in that way. And then if there's a question, I would still want them to see a provider so that they're getting a urine culture and we can really know what's going on. Like, I don't want people doing that and then just calling in and wanting an antibiotic, because they might not actually be having an infection, for one, and it might be, let's say, blood in the urine and they have something more serious going on. Or perhaps if they're just getting antibiotics called in, they could be resistant to it, and then their symptoms could go on into what you were talking about, where then they start having confusion, and they don't know because they're not burning with urination. They're not running necessarily as, the way that the bladder pain that they had when they were younger. And then they end up with something far more serious, and it can be confusing. Like sometimes people look at that and they'll think, are they having a stroke? Are they having, something like a pneumonia or something? But it very well might be a urinary tract infection.
You mentioned that the PCR testing is a little more expensive. Are the results available more quickly than doing the culture and waiting for those results?
The information can come more quickly, but it's, you're looking at a test that is quite a bit more expensive depending on what company they use.
Do doctors,
depends on the situation.
Do doctors often put individuals on prophylactic, kind of preventative antibiotics if they're prone to getting recurrent UTIs?
We do that for some patients. That is true. I would say I used to do that far more often in the past, but as I've been able to use estrogen cream and D-mannose and those kinds of things, I've way cut back on that and not had to use that kind of measure, because when you go on that antibiotic, it puts you at a little bit more risk for something like C. diff, which is a bacterial infection that occurs in the bowels and causes super diarrhea because your good bacteria is wiped out from the antibiotics. So I try to stay away from doing that if I can, but there are people that's what they have to have, or there are people that have to have an antibiotic with intercourse, and that's a decision that you would make with your provider.
Looks like there's a question that came in. Should you always have a follow-up UA after being treated for a UTI?
So the recommendation is not to have a follow-up UA, actually, which I know is surprising,
Right.
but that is, not the recommendation, actually.
Do the antibiotics then stay in your system for a certain period that after using that, perhaps I took my last antibiotic today, but it stays in my system for a week or 2 weeks, then I might still have symptoms that are decreasing over that time? Is there a time frame that if those symptoms aren't completely resolved, or if they come back, that we should be going back to the doctor?
So I have some women, think about your upper respiratory infection, and you take your antibiotics and you treat the infection, but your cough goes on for weeks and weeks and weeks. So think about your urinary system in the same way, that you can treat the infection and the bacteria, but the irritation might go on a little longer. That said, if I have somebody, I tell my patients, if this doesn't take care of it, I want to know. So they will call in and we'll talk about it. We'll have our conversation and we decide maybe it's time to go ahead and get urine tested again. And then we'll go from there and make our decisions if they still have a bacteria. And oftentimes they don't. It oftentimes is that they just have the irritation from the urinary tract infection. And so then we treat them symptomatically. When you have the cough, you take the cough syrup. Then we treat the bladder spasms, the discomfort, that kind of thing.
Okay. I think we see urology offices maybe underutilized by our members as they age, that it's really the primary care doctor that is treating or trying to treat UTIs. Are you finding that perhaps they're not getting referred to urologists as they should, as they're having these recurrent UTIs? And is that kind of I guess the question really is, it's not an anticipatory thing with age, that we would expect you to be more prone to having UTIs just by the virtue of getting older, that it's not normal aging processes. And so we still might need to see specialists and get testing.
Yeah, so as people age, certainly a larger amount, well, I wouldn't say a large amount, because I see a lot of young women as well, like those age ranges I talked about earlier, right when women start to become sexually active. But then I have women that, they haven't been sexually active in 10 years, they start having a new partner and they're, 30 some, I see it then too. It's mostly those risk factors, but certainly age increases the risk. So right around, the 65, and then once they get over 85, then we see even a higher risk.
Couple more questions in here. How long is it okay to hold your urine? Question.
I think you should pee about at least every 3 hours. I don't think you should go longer if you can help it. I mean, there are times when you're on a road trip, but see, that's also when people get those urinary tract infections, because when you go on a vacation or you go on a road trip, you just naturally dehydrate yourself a little bit because you don't want to be stopping to pee. You don't know what the situation is. And so when you're not peeing like you normally do, I tell people when you're not peeing, when you're not eating, and you're not having bowel movements like you normally do, because that's when you tend to get a little constipated, things just kind of get a little off. Or you have more time on your hands, so there's maybe a little bit more intimacy. That's when we get more UTIs.
Okay. This question says, can you talk about, and I'm going to pronounce it wrong, Mirbatec?
Mirabatric.
There you go. I'm sorry, her question is, I have used it and my urogynecologist would like for me to go back to it, but despite the information that it does not affect memory, my experience is that it was problematic for memory.
Wow, you're probably the first person that I've heard that's actually told me that they had trouble with memory. I'm not saying that you couldn't. It's just typically not a side effect of that category of drugs. So not to get too much in the weeds, but there's two main categories of drugs for overactive bladder. The main category of drugs are called anticholinergics. The side effects are dry mouth, constipation, and they, have the potential, because what they do is they stop acetylcholine, which is a neurotransmitter that goes muscle cell to muscle cell to muscle cell that contracts the muscles. And we're trying to stop the bladder from happening. But we have other muscles up here. So those can cross into the brain and sometimes cause some confusion, or there is controversy around that. There's concern. And I feel like I've seen that in some of my patients as well. The other class of drugs is the beta-3 agonist, and that's where Mirabatric lies. And those drugs, they work by causing smooth muscle relaxation, and they don't claim that they go into the brain. So that's why I haven't really, if I have a patient who's older, let's say if they're over 90, I pretty much only will give them Mirabatric, or there's a new one out in that category called Gemtesa. Coverage is a little iffy because it is new. But as we age, that becomes a concern, and that's why your gynecologist really would only want to give you that. I'm sorry that you had that, experience. If you don't feel comfortable with that, then certainly that would be a conversation to have with that provider. There are a few other options that for overactive bladder that are third line, which are more like procedures, and they can go in detail with you about that. But there's acupuncture, there's Botox, there's implantable devices.
Thank you. I think we might have hit on this before, but someone was asking again about the over-the-counter test strips, whether they're very accurate or not.
As I said before, I wouldn't use them to test your urine and say to your doctor, hey, I have a UTI, please treat me, because they can also be contaminated from your vagina, and they aren't a urine culture. But that's a conversation with your provider. I know there are providers out there, because medicine is a practice. It's not black and white. So perhaps your provider will use those, and that's a conversation to have with them. I will only use them if I have somebody that's getting them so frequently and they have also overactive bladder symptoms, because overactive bladder symptoms can kind of sometimes present similarly. And we're trying to figure out, is this a UTI, or is this like something overactive bladder, or they call it interstitial cystitis. Those ladies, they have quite different symptoms. They pee many times a day, or men actually too. And we want to just screen out that it's not a UTI, and that has been that might be something you would use for that, but it's not a recommendation. Like when I look at the American Urological Association guidelines, it didn't recommend that. I went straight through the guidelines, and that's how I made my presentation, and they didn't have that to list.
Okay, thank you. If there's any other questions, click on chat, type those in. We're lucky at Kendal at Home to have a great relationship also with Dispatch Health, which is an urgent care on wheels that will come to your home and test for UTI is one of the things they will, services they're able to attend to, as well as getting that antibiotic ordered for you, sending away that culture. So that's a nice feature where if you're not able to leave your home, or you don't want to go to the emergency room and you're feeling, under the weather or having any of the symptoms or things that Anna referred to, that Dispatch Health can come out as well and test for you too. One more question. It's been amazing, and they usually come out within 2 hours or so of you calling, which is wonderful. So, do you recommend any best brands of adult briefs for best absorbency to keep urine at bay in the briefs?
I think that Tena has always been a little bit of a leader in products. I kind of steer away from Always brand, because I feel like, I hate to name brand, but I probably shouldn't have said that. Just because I feel like that there can be irritation there myself. And I try to look for brands that have, more of the, and now we're fortunate because more and more are coming out all the time where they're, more hypoallergenic and not causing irritation. So those are the kinds that I look for. I can't say that there's one that I find superior than others, but I do know that I've had patients that have been pretty successful with like some 10-up products.
Okay, great. I don't see any other questions, but I am so thankful to have you with us today and providing this information. It is so important for everybody to know those warning signs and symptoms and when to reach out to the doctor. And really, no symptom is too small, I think, is the biggest takeaway. For today, worst case, you get tested, see your physician, and it's not a UTI or a medical concern.
You don't need to feel bad about that. If you go in and it's not, it's better to get it checked out.
Wonderful. And if local members are interested in visiting your office, do they need to have a referral? Does it depend upon their insurance? They can call directly and make an appointment.
I would say typically most patients can just call, and I think they probably know by their own insurance. There's so many different Medicare products now, so they know by their own insurance if they need a referral. But
okay, wonderful. Well, there's lots of information. So we did record today's session, which will be available to our members. And we will be sending a link out as well, because it's really important for everybody to hear all of the information you shared today. So thank you again for being with us. And thank you everybody for joining. Have a great weekend.
It was my pleasure. You guys have a great holiday season.
And thanks, you too.